Hey, are you ready for a report?
Yes.
All right, so this is Mr. Hart, date of birth 4/1/65. So he's here today for cardiac surgery, CABG, coronary artery bypass graft. It was CABG times 2, Lima to LAD, and left saphenous to left circ. Arrival time was at 1100. His pre-op EF was 30% and post-op was 40%. In terms of his past medical history, he has CAD, hypertension, diabetes type 2, OSA. He does use CPAP at night, and gout. In terms of allergies, he is allergic to penicillin, morphine, and peanut, which he has had anaphylactic shock in the past. Alright, so this is Mr. Hart, really nice gentleman. Neuro-wise, he is align-oriented times 4, very pleasant. In terms of pain, we are controlling his pain with oxycodone 10 milligrams PRN. It is ordered Q3 hours, and he is able to let us know when he wants to take pain medications. On top of oxycodone PRN, he's getting the Tylenol, gabapentin, which is the multimodal pain medications. In terms of temperature, his Tmax during my shift was 36.9 Celsius. Currently, he's not getting any sedatives and he's not restrained. Resp-wise, he was extubated at 1400, and he tolerated extubation just fine. Currently, his nasal cannula was weaned off to 2 liters, and currently he's sitting around 95%. Saturation goal with him is 92% and greater. I'm encouraging him to use the IS, and he's been doing that just fine. His lung sounds clear to diminish. He's been coughing here and there, and I'm encouraging the cardiac surgery protocol to hold the pillow in front of him when he coughs. Cardiac-wise, he's normal sinus rhythm. Heart rate has been anywhere from 60s to mid-70s. Our pressure goal is not greater than 65. On arrival, he was a little vasoplegic, so he was getting a couple of mic of norepinephrine, but that was weaned off at 1400, and since then he hasn't had any vasoactive medications with me. He has AV wires, epicardial wires. Currently, it is set up to be backup rate of 50, and MA-wise, AMA is at 5 and VMA is at 6. He hasn't needed any pacing during my shift as well. Hematology-wise, he has received aspirin 365 milligrams on arrival rectally, and that's pretty much it. Tomorrow we're going to resume the heparin subcutaneous for his anticoagulation. GU-wise, he has Foley for close urine output monitoring. His urine output has been okay until 1600 when it dropped to 20 cc an hour. So I gave him PRN albumin times 1, but honestly I don't think it did anything because it still has been 20 cc an hour in terms of urine output, and last hour it dropped to 15 cc an hour. So I did communicate with the provider, and our plan is to continue monitoring, and if it keeps dropping or if it keeps within this range, then we might give him IV Lasix times 1 to see what happens. His latest creatinine is 0.96. GI-wise, after extubation, he did a pass-follow evaluation, and then he's been tolerating full liquid diet just fine without nausea, vomiting. His bowel tone's positive as well. Last bowel movement was yesterday at 9 p.m. and that was prior to surgery. For his insulin, he's getting insulin drip algorithm 2, and the dosage is 0.9 units per hour. And with this algorithm, his sugar has been stable as well. Mobility-wise, per cardiac surgery protocol, we did dangle him after extubation within 4 hours, so 1800, he did dangle. During the movement, he did complain of some dizziness and then some slight nausea, but after getting used to the position, he was able to, or the symptoms subsided. So with this protocol, we are to move him to the chair at 2200. So I just wanted to let you know that. In terms of skin, he has mediastinal incision site covered by Medipore. It's clean, dry, intact currently. He has left lower extremity Medipore, and ACE wrap is covering that, clean, dry, intact as well, and that is from the saphenous graft site. He also has that Alavin on his sacrum, and that's just a preventative measure. Underneath Alavin, skin underneath is clean, dry, intact as well. Lab-wise, it was drawn as 1600. Nothing really significant. White counts 13, platelet 112. Age nature currently stable-ish, 8.0 and 25.2. All the electrolytes are looking okay, except for ionized calcium on arrival. It was 1.01, so I gave him 2 grams of calcium gluconate. And after that, I checked it with iStat, and it was improved to 1.22, so no further action was taken. Magnesium on arrival was 2.2, so no replacement was given for that. And potassium on arrival was 4.3 as well, so electrolytes are all looking great. Line-wise, he has right IJ triple lumen, central line, right arterial line, radial site is looking great, and blood is drawing just fine. Left forearm 20 gauge PIV. In terms of drains, he has mediastinal chest tube. The last output was 210, so I marked that. And hourly output wise, it was like 10 to 20 cc an hour, so nothing too big. And he also has a left pleural JP. I've been emptying every hour, and it's been like 10 to 15 cc an hour, serosanguinous, so nothing too crazy there either. Drip wise, again, just to go over, insulin drip algorithm 2 at 0.9 units an hour. Norepinephrine is turned off currently, and so is the butamine, but if you think that the patient needs them, then they're already in line, so you can just restart them as well. So plan-wise, we are going to continue to monitor his urine output, and also hopefully he will tolerate the chair time. And I think if those two things are checked off, then probably in the morning he can transfer to telemetry unit. Do you have any question?
No, thank you, son.
All right, have a good day, or have a good night. Alright guys, so I hope you enjoyed my shift change report, and that's how I would normally give shift change report to my colleague. Now I want to point out a couple of things before I go into details about each component of SBAR tied into my shift change report. So the first thing is that I'm aware that you guys have been learning SBAR format in terms of giving report to a physician. And that's why the R part is recommendation, like, hey, Dr. So-and-so, I think this needs to be done, something like that. Whereas here, with my case, I did the shift change report, so I used the R part as plan. So plan for this patient for the night shift is this and that. So, plan, recommendation, they're kind of similar and can go hand in hand, but I just wanted to point out that when it comes to SBAR report or SBAR format for shift change report, I use the R part as the plan. The second one, some of you might have felt like, oh, Sun is giving report for so long, and I totally agree with you. Actually, it was 7.5 minutes almost. And normally speaking, I would give report within like 5 minutes or so, because you don't want to keep going and going. That's a little ineffective and disorganized. So the reason it took for me to film like 7.5 minutes is that I spoke much slower than what I would normally do, and also I didn't use as many abbreviations as I normally would. But yeah, again, I would normally be speaking a little faster, and I would try to make it a little more concise and faster. That way, you're not doing like an ineffective shift change report. So I wanted to point that out as well. So now let's go into each component of SBAR. So I prepared this. Very fancy. All right. So SBAR, S, situation, as you guys should be aware already. So this is where you talk about situation, obviously. And inpatient setting, particularly, this is where I talk about why the patient is here in the inpatient setting, in the hospital, acute care, ICU, what have you. That's because, normally speaking, these people do not belong to a hospital. People belong outside hospital, living healthy life, but unfortunately, there is a particular reason that patient had to come to a hospital and get a treatment. So we really need to know why the patient is here and what can we do to get this patient like out of hospital. It's always our goal. So that's why it's important from the get-go to talk about why the patient is here in this inpatient setting. So when it comes to my shift change report, that's where I talked about he had a CABG cardiac surgery. And I went into a little details about his cardiac surgery, but basically this is where I talk about why the patient is here at the hospital, right? Next one, background, so B part. This is where I talked about patient's medical history and allergies. Medical histories are really important to know because, like, for example, the first thing I mentioned was CAD, coronary artery disease, that directly ties into why the patient is here. So he had some occlusions to coronary arteries and oxygen was not flowing in, and he had to have that bypass surgery there. So that's why you need to know why the patient have this medical history, and that kind of leads to his surgery, right? And also I'm talking about other histories such as hypertension. Then we need to watch out for his blood pressure because he could go hypertensive, which could go into complications such as graft sites bursting. So back in my head, I'm already building like worst case scenario. Diabetes type 2, again, his blood sugar might be difficult to control. Gout, he might complain of pain, and we should resume his gout home medications for gout, things like that. OSA, obstructive sleep apnea. I already talked about he has talked about the fact that he has used a CPAP at home, and we need to make sure that he has it here. If not, we need to prepare that for him. So talking about past medical histories give you so many pictures in terms of this patient's particular care. So again, it's important piece to tie in the background. Allergies, obviously, it's very important. If he has had allergic reaction to or anaphylactic reaction to peanuts, do not give peanuts to this patient. Okay. All right, so assessment part, I think this is very self-explanatory, and I went into so much detail about assessment part, and I think that's the way it should be, because this is where you talk about head to toe, what you have noticed, what you have observed, what you have found, everything. The important part, I think, in this piece, assessment part, is that you go into the system. So as I did, I went into like neuro-wise, respo-wise, cardiac-wise, skin-wise, blah, blah, blah. If you don't compartmentalize your assessment piece and give report that way, then your report will be very disorganized. Like you will be jumping from like one topic to another and coming back, and so it's going to be very disorganized, and my thought process will be disorganized as well. So I think it is very important to give very organized shift change report, and this is the way I try to at least organize my train of thoughts by creating compartments. So neuro-wise, respo-wise, blah, blah, blah. All right. So again, I talked about recommendation part at the beginning of this video, but this is where in terms of shift change report, I talked about plan. So what's the recommendation to the night shift nurse, meaning what's the plan that I have for night shift nurse? So again, recommendation and plan, they are very similar in my opinion. And that's when I talk about plan is this and that. And again, plan in terms of inpatient setting. For me, ICU setting is all the patient's plan should be get the patient out of ICU. That should be always in our plan. And I always think about what we can do to accelerate that process. That way they can go out of ICU and consequently go out of telemetry floor, meaning discharge. And that's always our ultimate goal. So always when it comes to plan, in terms of inpatient setting, think about how to get the patient out of whatever the setting you're treating the patient in. Okay. All right, so that's how I do my SBAR report. Yeah, so I hope that was helpful for you guys. And if you guys want to practice SBAR report, I'm always here for you, and please utilize office hours. But I just wanted to create this video, that way at least you have like a example of how a nurse would do a shift change report. And I also wanted to go into details about the thought process behind my SBAR report. Okay, that's it. Bye.